Okay, great. Welcome. We're very excited to have you here for our symposium, which is the Spring Symposium of the Center for Global Public Health. And we're very excited to have it be focused on essentially the challenge of slums, as we've called it, global health in the urban century. And this is actually a follow-on from last year's Spring Symposium, which was about the global change, and we had a very broad perspective, and it actually out of that conversation, first of all, came a focus on urban, and then out of the symposium itself came this focus on slums and on slum health and associated issues. And so this is essentially directly as a result of the last year's symposium and on work that's been happening throughout the year with faculty and students that are part of the Center for Global Public Health. And so what I'm going to do is just give a brief overview of the center and the BAG, which is the Berkeley Alliance for Global Health on campus. And then I'm going to run through just an introduction to this particular symposium and end with essentially just an overview of the schedule for today. And then I'm going to pass it along for introductions to our keynote speaker and then the panels thereafter. And so I'm just going to get started to remind you that about 2 years ago, we finally were able to coalesce all of the global health work on campus, spanning from the very upstream discovery to the bench and the community. And so what we did is we really combined essentially two centers which were just coming into existence, which is the Center for Emerging and Neglected Diseases and the Center for Global Public Health. The Center for Emerging and Neglected Diseases is another faculty and student initiative which combines a lot of work in biology, molecular biology, chemistry, engineering, etc. And the idea is to move from discovery to delivery and through trials and through collaboration with industry. And it's very closely kind of connected with our Center for Global Public Health, which actually takes it essentially from our research here in the university on many things, including laboratory, but of course, epi, policy, human rights, a number of kind of broader issues, and then really translates that into the community. And so I'm going to go into now the long-standing track record that UC Berkeley faculty, especially in the School of Public Health, have in international research, which was what drove us to kind of bring everybody together. And so the Alliance is about 80 faculty in 44 colleges and 5 professional schools. Actually, now it's over 30 countries, and you can see where some of these countries are. This is actually, and forgive me in the morning, this might get you a little bit nauseous, but I'm going to see if I can make this work. This is a very lovely Google Earth depiction of some of our projects. This is actually where I work in Managua, Nicaragua, on dengue. We have projects in Costa Rica, in Guatemala on childhood pneumonia. This is just kind of leading you through Argentina, arsenic and lung cancer. This is really just looking at Brazil, TB, drug resistance. You'll hear a little bit about that today. In Chile, these are just projects that are ongoing with faculty from the School of Public Health. And you can see Afghanistan and Bangladesh, and then this is ranging from environmental health to infectious diseases to maternal and child health. There's a whole number of different projects, and as you can see, that was in Nepal, and then a number in Africa, postpartum hemorrhage. We're going to hear some of that work today. Zimbabwe, STD prevention. In Nigeria, also maternal mortality, as well as in Tanzania. And this is in Uganda, maternal health. There's also malaria. So this is actually done a couple years ago, and would actually have to add to that. So now we can get even more dizzy. But this is just some of the faculty that are associated with the Center for Global Public Health work in many countries, and The idea was really to coalesce and have essentially a single place that people could come, people who are interested in the campus, people who are on the campus, students and faculty as well, to find out what in the world their colleague is doing when they're absent from the faculty meeting. No, just kidding. But the idea is that, that we actually were amazed to find out how much activity there really was. And what's really important about this is that these are not kind of fly-by-night, oh, I took a trip one day. Almost everything here has about 10 to 30 years of experience and really, truly collaborative research. I think that's one of the things we're most proud of at Berkeley, is the approach that's taken as a kind of true partnership over time. People never made a big fuss about it because they were busy doing the work. And so we finally realized that global health being such a trend that we actually had to kind of establish ourselves in a more formal capacity, and that's where the Center for Global Public Health came from. And so one of our most important activities is to run a fellowship program for students. These are master's students and PhD students and PhD students who have option to apply in a competitive process for a 2 to 3 month internship overseas, mostly during the summer, but it can also be during the year. And this is just, we've been doing this now for 3 years. We send 8 students per year. We just did our selection for 2010. So this was the group that went in 2007, and these in 2008. And now, starting with Melissa, we're going to have another group going to a number of different sites, as you can see, in 2010. And these range, really, it's amazing, across all disciplines: environmental health, infectious diseases, policy, maternal child health, just a really broad range of expertise and projects that are very exciting. And then when they come back, we have a symposium where the students present, and that's really fun, so keep an eye out for that. We also have banner research projects, and we went through a long process, 2 or 3 years, to identify what it was that the faculty and the center were going to get behind. And as I mentioned, part of that process was being very broad, and we started out with global change on a very broad level, and then came down to this question of the challenge of slums, which actually, ironically, was one of the very first projects that we started off with as an idea with Lee Riley and Jason Coburn and a number of others here. And the idea is here that it's kind of being sprung out of the Center for Global Public Health, but really it's a broad initiative across the entire campus. And as you'll see, there's people from the College of Engineering, from city and regional planning, from a number of different disciplines to address this extremely multidisciplinary issue. And so the idea behind this is that there's over 1 billion people living in slums worldwide, and more coming every day, with the projection of reaching 2 billion by 2030. And this is really a critical research need, especially since there's urban health, but really the slums kind of are excluded from almost everything in terms of access to health care, even access to metrics, so access to anything, and there's very little knowledge about what's going on, and it's a very different system, economic system, health system, everything system, land rights system, so that it needs pretty much, it's not just part of urban health, it's actually really its own beast. And so this is not just us recognizing it. There's a report by the WHO and others that have been written many years ago on this subject, but we're really taking this seriously and seeing what UC Berkeley with its students and faculty and its really amazing multidisciplinary character can do to advance both the research and the translational impact of work in this area. So this particular symposium is hosted, as I mentioned, by the Center for Global Public Health, also proud to be hosted by the Bixby Center for Population Health and Sustainability, Malcolm Potts and Martha Campbell and others. We've been working very productively over the last number of years, and particularly towards this symposium, and Venture Strategies for Health and Development, which is a component as well of this effort. The background is that Berkeley, we've been focused, as I mentioned, on global health long before the term was coined, and we have this kind of move towards really interdisciplinary approaches. And that we were looking for something that was very complex and that needed this approach, and it was something that really excited people both in the faculty and the students and was very topical. And so it seemed like this was the perfect question to address. As we mentioned, there's more than half of humanity lives in cities, but as I mentioned, that this idea of slums is actually separate from just plain urbanization, and that we have already a number of different commitments and capacity at UC Berkeley at a number of areas of global metropolitan studies, school public health, economics, engineering, as I mentioned, environmental sciences, and that the idea is that to focus on urban spaces and their inhabitants would lead to a more concrete solutions-oriented approach. So, research is fine, but we want actually to do something at the end of the day. And so the idea is to broaden the dialogue, share information that's existing in our planned research, and add new perspectives. This is not us talking to you, actually. The reason for this was so that you could talk to us. We have ideas that, and the idea right now is that we're kind of formulating a research strategy and translational aspects to that, but that we want to hear from you about experiences that you've had, things that you've seen work or don't work. A number of people have had international experiences, and we, of course, have very honored guests with us who are going to give us their perspective as well. And what we want out of this is to define opportunities and to form more cross-campus solution-oriented research teams. And eventually this will end in a white paper and proposals and to generate interest on the level of the funders. We're excited that through the Institute for International Studies, we were we went through a competitive process and we were granted funds to do a colloquium series, which is going to be a 3-semester faculty colloquium, which of course includes students and other activities, beginning in the fall of 2010, and it's on precisely the topic of slum health. And this includes faculty from the School of Public Health, City and Regional Planning, engineering, civil and environmental engineering, and others. And the idea was that this particular symposium will serve as kind of the kickoff to that. And so I'm just going to close with the approach that we're aiming towards here is to engage faculty and students to leverage the strengths and then to foster links. Many of us, as I mentioned, have links overseas. So the idea is to bring all of our international partners into this process to diagnose problems, analyze the drivers, address the health consequences, but more than anything to catalyze solutions. And that, as I said, is something that Berkeley's kind of known for, is to really get out there in the field, and that's what we're hoping to do, focused on this particular problem. So just my final slide is a symposium design. The objectives, as I mentioned, to increase the visibility, to promote interdisciplinary dialogue, to set the stage for this faculty colloquium, and to network in and amongst ourselves. We're going to have a keynote address that we're going to start out with, and I think, George, are you going to do the introductions? Martha's going to do the introductions, and then we're going to have panel discussions. One of them is going to be a panel of 3 Berkeley faculty who have ongoing projects. Kara Nelson, Jason Coburn, and Lee Riley, which I will moderate that panel, and they'll tell us about some of the ongoing studies and where they're directed and what issues need to be addressed. We're also going to have a number of other presentations, a conversation. It's going to be kind of a panel conversation with you as well, and then another talk right after about essentially novel financial strategies for working in slum areas. And then the idea is that we have a participatory lunchtime discussion where there's going to be 10 tables set up it's not only free lunch. You actually need to contribute your intellectual prowess to this, because there are flip charts that are going to be at each table. And the idea is to really kind of have that conversation continue among these small tables where you really share your experiences and then your comments, your thoughts, and about where you think this can go, and we'll have a note taker at each table. So with that, I'm going to thank you. We're going to have the specific thank you to all of the wonderful people who have helped put this symposium together at the end, but I've been told that I'm out of time, so. Okay, sorry, I'm going to stop this right now. Okay.
Yeah. Hi, I will keep this very short. My name is Martha Campbell, and I want to introduce our honored guest, Eliya Zulu, whom I met in 1997 when I heard him speak in Arusha, Tanzania, boldly talking about the population factor in everything that Africa is trying to do. And especially, he has a special talent, actually, for translating research into policy. He's here as a guest of Venture Strategies for Health and Development, And as a matter of fact, he holds the title of Director of Development Policy in Venture Strategies. We are keenly interested in the fact that, that when you have rapidly growing populations, it's very, very hard and often impossible to improve health, to expand health and education, get out of poverty in any country, in any part of the world. We're just very glad to have him here, and there's a lot written about him in your program, so I won't say any more here. And Eliya, would you like to come up here? And thank you.
Good morning. Still morning, right? While the computer is being set up. Yeah, as Martha said, I'm Eliya Zulu. I work at the African Institute for Development Policy, which is based in Nairobi. And since I don't get a chance to look at my slides, I'll say one or two things about AFIDEP, which is the institution that I work for. It's a new institute, and the main aim is really to promote the translation of research evidence for policy-making, decision-making in Africa, with the argument basically that although there's generally weak capacity for research in Africa, the truth is that substantial research is taking place on the continent, but it's scattered all over the place. And so what we are trying to do is really to synthesize all this evidence and more proactively engage with policymakers to enhance utilization of the knowledge. So thanks a lot for inviting me to this symposium here. I should also start by acknowledging the fact that most of what I'm going to be talking about here is based on my experience working at the African Population and Health Research Center, where I worked for the past 13 years or so. And part of my work there involved managing the Urbanization and Wellbeing Research Program, where we set up a longitudinal study in 2 slum settlements in Nairobi. Actually, that was the first sort of a longitudinal study to be set up in a slum settlement. So basically, I'm going to talk, I'll just look at briefly, look at the population figures and trends in population, especially in relation to urbanization. Look at the characteristics of slum dwellers. I think I should also acknowledge, I should also say upfront that most of my experience working on issues to do with slums is based on Africa. So my talk will really mostly focus on, will more or less exclusively focus on Africa. But I think that those who have worked in India, the slum settlements in Delhi and so on, would agree that the issues are more or less the same. So then I'll look at the unique challenges that are faced by the urban poor in the African setting, with particular focus on the data that I'm familiar with, the data we've been collecting, we're collecting in Kenya, and then go on, finish by looking at some of the options and opportunities for addressing the urban health vulnerabilities that slum dwellers face. So you've probably seen this chart before, basically trying to show that if you look at population growth, global population growth, basically there's already some sort of a stabilization of growth in the developed world. Some countries experiencing some decline in growth of their population. So really, when you look at population growth, it's going to be really the developing world. But also a very, very critical thing is the issue about urbanization, that there's this, we've actually crossed the milestone now where we say globally there are more people living in urban areas than rural areas for the first time. So when the growth is, most of the growth of the population will actually be concentrated in urban areas of the developing world, as this chart here shows. So the crossover in the developing world is delayed a little bit in terms of having more people in urban than rural areas, happening around 2020, although globally we've already crossed that. But I think another critical thing we need to know is when we talk about the developing world, we need to see, also compare where this push in growth of the population is mostly happening. And if you dissect the developing world segment into the least developed and those who are less developed, you'll see that actually that intersection for the least developed countries is actually happening much later, after close to 2050. So there's still a lot of growth of the population of rural areas in the least developed parts of the world. And this is the same sort of pattern that you see that sub-Saharan Africa actually exhibits, since most of the countries in sub-Saharan Africa are actually among the least developed. That's the pattern you see there. And as many of us know, like the Gates Foundation just recently launched this big urban health, reproductive health program, with the understanding that since most of the population growth is going to be happening in the urban areas of the world, and there's a lot of unmet need for family planning, where a lot of women who don't want to get pregnant are actually not using contraception, then they have launched this big program to provide lessons on how you can reach out the urban poor. But so I just wanted to say here that I think these figures, especially for sub-Saharan Africa, there's still another 20, 30 years of quite rapid population growth in rural areas. And we can't just, while we are saying that we should focus on urban areas, we can't ignore the rural areas. Where is this growth? What is really driving most of the urban growth? If you look at developing countries, as a whole, 60% is due to natural increase versus 40%. But in sub-Saharan Africa, actually it's 75 to 25%. So a lot of people tend to think that growth of the population of urban areas is mostly due to migration, people coming from rural to urban areas. But the truth is that a lot of this migration actually is secular, where people come and go and so on. But the actual increase in the numbers is mostly driven by the birth rates, the children who are actually being born in urban areas. So urbanization, why should we be concerned about this? I think that if you look at the relationship between, this chart here is looking at GDP per capita and the percent urban. You see that basically there's a positive relationship between the two. So urbanization is supposed to be a good thing. I think that a lot of the development that happened in the West and so on was, I don't know whether urbanization was an effect of that, or urbanization helped to drive that. But I think there's quite good reason to think that urbanization is a good thing for development, or it's a good indicator of development. But the reason why we should be concerned for the developing world is that urbanization is happening at a time when poverty is growing, when the economies in the developing world are actually not able to generate enough jobs for people who are increasing in the urban areas. So like this chart here, if you look for examples from 3 African countries, it's just showing you the proportion of people living below the poverty line. And in Nigeria, for instance, so you have data for 2 points in time, 1985 and 2003, and you see that the proportion living below the poverty line in rural areas actually declined. In Ethiopia, the same. In Kenya, it increased a little bit, but the increases in the proportion of the urban dwellers living below the poverty line is actually much bigger. So poverty is becoming more of an urban phenomenon across the developing world. And the big reason why we have to be concerned about the rates at which the developing world is urbanizing is the fact that most of the people the poor living in urban areas are actually ending up living in informal settlements or slum settlements. You can question these data that were produced by UN Habitat in 2003, especially I've presented this, and some people from Ethiopia have said, how can you argue that over 90% of the people in Ethiopia actually live in slums? But I think what UN Habitat did was to use a measure of slum settlements, which is, using the definition whereby if you are living in an urban area and you lack 3 of these 5 things, inadequate access to safe water, you lack adequate sanitation, or you live in a crowded area, or poor structural, the housing is made of non-durable materials, or you lack the security of tenure, that you are more likely to be living in a slum settlement than not if you are living in a city. Because these are the basic sort of amenities that are associated with city life. And those people who lack 3 of these at least would be more likely to be living in the slums. And based on my experience working in the slums in Nairobi, I think this is quite a valid sort of proxy for estimating people who are living in slum settlements. So these figures have to be quite worrying, where you are looking at over 2/3 of people. Look at sub-Saharan Africa, about 72% of all urban dwellers are living in slums, or if you don't want to call it that, they're actually living in conditions where they lack the basic amenities that are associated with living in urban areas. And these are the projections. Actually, if you look at the urban versus rural population growth rates, you see that in many African countries, urban areas are growing at between 4 and 5% per annum, which means the urban populations would actually, if that is not reduced, would double in about every 15 years. Rural areas are growing at a slightly lower level. So in Africa, between now and about 2020, you actually have the slum population actually more or less doubling. So what are some of the features of the slum dwellers based on the data that we've been looking at in Kenya? This is a population pyramid, which basically shows you the age-sex distribution by 5-year age groups for females on the right-hand side and males on the left-hand side. And this is quite a fascinating population pyramid. I think for those who understand, who have studied demography, would just look at this and wonder what sort of pyramid it is. It's a pyramid that kind of shows that it's a crisis sort of living arrangement where people are just coming in and out. People are not really bringing up their families there. So it's characteristic of a pyramid that might be in a war-torn sort of area where people are just, you have adults who are there to work and then everybody else is living. You don't have many old people, you don't have many children. But I think one interesting thing here is that when you look at the reproductive age group, say if you take men, out of the total population, 36% are men aged 20 to 54, and 26% are women. So there's a big gender sort of imbalance there, which has quite big implications for reproductive health, sexual networking, and so on. Okay, you also try to understand who are these people who live in the slums? Where did they come from? Where, and this chart here shows for the 2 slums where we were working that only 25, in one of the slums, which is more settled actually, more stable, 25% were born there. In the other one, only 5%. And the other one called Viwandani is actually in the industrial area in Nairobi, where mostly people go there to work. So I think this data here show that you can't also just look at slums and think that they are the same. They are quite different, but most of the people, those 70% and 91% born outside Nairobi are mostly coming from rural areas. How long do they stay there? You see here that the average is actually, I think this data, you see that the proportion of people who have stayed in these communities for more than 10 years, in this other slum it's 57% versus 26% for males, for females, and 63 versus 36% for males. So in general, males are staying in these places longer. But I think what would be more interesting also is to see, what would be more quite interesting is also to see, for those people who are coming in, this chart here looks at people who came in the last 5 years. How long are these people staying? And you can see that for people who came in the last 5 years, about half of them who have left the median duration of stay after 22 months or to 26 months in one community and 18 to 21 months in the other one. So there are 2 categories of people who live in slums. There are people who stay there for a long period of time, and there are others who come and quickly leave. So when you're talking about interventions, when you're talking about what you want to do with this population, you have to understand what sort of a population you're actually dealing with. Also, when you get into the issue of what are really the challenges, we can define it ourselves, look at the slums and say, what are really the issues there? What do we want to do? But it's very important that you should also listen to the voices of the people living in these communities. In 2000, we did a major study in Nairobi, a representative survey of all the slums in Nairobi. And this is what people came up with when we said, what is your most important concern? And you can see here they are talking about jobs, housing, toilets, water, and education as the 5 most important. And for jobs, that is quite understandable. Most of the people come to Nairobi or to the cities to improve their livelihood opportunities. But look here, if you look at the population in the slums of those aged 15 plus, only 20% of the men were actually in salaried employment, and 4% of the women. So although people are coming for jobs for the most part, the reality is that the jobs are not there, and they end up doing these odd jobs and so on. So that's the cause of the frustration, saying that jobs is the most important thing. And I think another key thing to note there is that health doesn't really come up in the definition of health services as one of the key things. Although when you go to ask them specifically and say, what are your main health concerns? You see that they are looking at toilets, drainage, and water supply as the main health issues. So for those of us who are mostly maybe interested in health services and think that health is about services and so on, for slum dwellers, it's the environment that is the most critical. And that's the message you are getting here. HIV/AIDS, of course, is a big thing in Africa, getting more the lion's share of development money. But I mean, if you go to the slum setting, it's really the environment where people are living that is most critical. And when we talk about the environment, you look, there's high congestion there. 60% living in 5% of the residential area in Nairobi. People live typically in a one-room house, a family. It might be a family, and the average household size in Nairobi is about 3 in the slums. But they live in one room, which they use as a kitchen. They cook there with the obvious environmental concerns, a sitting room, and some people even shower in their own rooms. They don't have proper toilets. These are some of the toilets people use, and many of these are even, they have to pay to use them. Otherwise, a lot of people don't have toilets at all. There's this phenomenon in Nairobi called the flying toilets, where people actually, because they don't have a toilet, they go in their own house, use a plastic bag, and they just throw it. And so they call it the flying toilet. And it all ends up in these, rubbish sort of places like what you see here. There's also the big issue of poor drainage, which is really provides a very, very conducive environment for transmission of diseases. Another concept is what they call the floating toilet. So you see here there's some sort of river down there, and people just build a toilet, and you just sit there, and so the river takes everything away. So, but I mean, if you are looking at Nairobi, where 60% of the population is living in these conditions, we have to ask ourselves, for how long should governments and the international community and everybody allow this to continue? Water. Most of the people there use tap water. And on the surface, you might think that, oh, that's what everybody is fighting to get. But evidence has shown that the water, that is the tap water that people in the slums use actually, is very, very contaminated because people steal the water using plastic pipes and they get contaminated. But also, more critically, it's much more expensive. That some studies have shown that people in the slums actually pay 10 times more than what I pay in Nairobi because they are buying these small bits of water. So the poor are actually being driven deeper into poverty by some of the things that we take for granted ourselves. I talked about the natural increase of the population. I think the evidence also, this is not necessarily from these are a number of countries in Africa using the demographic and health surveillance data, showing that actually many poor urban women have unwanted children because of lack of family planning. So this chart here is just showing the urban poorest, who are likely to be the slum dwellers, the urban richest, and comparing with the rural. And what you see is that the people who are living in slums, who are actually living in the cities, and we expect them to have access to health care and so on, they are doing as worse, or in some cases worse than people living in rural areas as far as access to family planning is concerned. And that's why I think the whole issue of the natural increase, the increase in the population in urban areas, is going to be a very, very big issue because some attention needs to be paid to these issues. And clearly, the burden of high fertility is disproportionately borne by the poor. This is one very, very nice chart I like about Kenya to illustrate this point, that if you compare the ideal family size, what women say they would desire to have versus the number that they are having, you can see here that these are wealth quintiles, so you are looking at poverty levels. So the richest people want 3.1 children, they are having 3.1 children. The poorest people are having 2 extra children. And so the issue is family planning is such a basic sort of tool, but we are failing to reach the people who are in need of these services most. You look at other things like vaccination. Less than half of the children in the slums of Nairobi, which is supposed to be, it's in the city basically, are fully vaccinated. The lowest of all geographical areas in Kenya. The same thing when you look at diarrhea, the incidence of diarrhea. People in the slums, and that's expected when you look at the pictures I showed about the environment. But basically that even the people who are the richest are doing better because they can buy good sanitation in their houses and so on. But the gaps are big even for the richest people between the people living in slums and those living in rural areas. And the obvious sort of implications of this, is actually, the ultimate implication of this is what you see in the levels of mortality. The number of children who are dying in the slums compared to other parts of Kenya, for instance. So in the study that we did in 2000 and comparing with data collected in other regions or nationally in Kenya, you see that out of 1,000 children that are born in the slums, 151 die before they reach age 5, compared to 62 in the whole of Nairobi. That is including the slums, so which means if you take out the slums, the non-slum parts of Nairobi is actually much, much lower. And compared to 113 in rural parts of Kenya. In terms of infant mortality, out of 1,000 children born, 91 are dying in the slums before they reach age 1, compared to 76 in rural areas and so on. So really, you see that if this was a small population and so on, you can say, okay, we can ignore it and so on. But when we look at the statistics showing that increasingly more people will live in urban areas, and the vast majority of the people living in urban areas are living in these conditions, it simply means that all this push about achieving the Millennium Development Goals, about improving global health and so on, we can't achieve it if we ignore people living in poor urban settlements. The same pattern you see when you look at HIV/AIDS. We did for the first time a community-based testing of HIV in the slums where we're working. And while we understand that urban areas typically have higher HIV prevalence than rural areas, you see that in the cities themselves, you have to look at what this means for the slum population, which the figure here shows clearly that they are more vulnerable to HIV/AIDS. Even when you look at young people, this chart is showing age at initiation of sex. And it's clear here that actually children who are growing up in slums are initiating sex about 3 years earlier than children living in other parts of Nairobi, with the obvious implications that we know and so on. It also extends to schooling. First, when you look at the net enrollment ratios, you might think that, oh, there isn't such a big difference. But when you go to the second set of bars there, the proportion who are transitioning to secondary school, you see that the slum dwellers are much more disadvantaged. And also just to mention that in Kenya in 2003, the government started free primary education in order to allow the poor children be able to attend school and so on. But what you see in the last set of bars here, in the research we're doing in the slums, comparing to some other low-income non-slum parts of Nairobi, is that actually the poor, the slum dwellers, are less likely to be in public schools. So the policy was there to help the most disadvantaged people, but they are not able to access this because there are no public schools in the slum settlements. The sort of schools you have there is what you see on the left-hand side. Actually, that is a school with that small window there. versus the government school that is on the other side. So let me just run through this. Also, the other critical issue is about the health system. We did a study just to map the nature of health system, health services that people in the slums use. And so what we saw is that actually, we did this in 3 major slums in Nairobi, and 85% of the healthcare providers are non-public. I mean, private for profit. 1% were government, but the government were actually 6 clinics that were in the outskirts of the slums, because no government services are within the slum settlements themselves. So these are the sort of clinics. When you look at the informal, most of those are for-profit sort of clinics. They don't have adequate facilities. They are poorly equipped. They are usually staffed by unqualified personnel and so on. This is one of the clinics that is advertising here that they provide maternity services, dental services, minor surgery, such as circumcision and so on. But those are the services that many of these people are actually using. Another major source of health care in the slums are drugstores. In these 3 slums, we actually counted 388 drugstores. And many of these are actually not registered by the authorities that are supposed to register them. And also, they are not registered. They don't have licenses to operate business by the City Council of Nairobi. So the obvious implications are that you have a lot of counterfeit drugs being sold and so on. And okay, this was just trying to show what are the main causes of death for the young people and the older people. But I'll quickly run through it. For young people, it's basically pneumonia, the top 5, pneumonia, diarrhea, stillbirths, malnutrition, and birth injury. So those 5 actually account for over 60% of all deaths of young people. While for older people, it's mostly HIV and AIDS. But I think the main point to note is that when you look at children, mostly, is that when you look at the main causes of death for children, about 81% of them can actually be addressed by interventions that we already know. Interventions that we already know have proven to be effective. The only thing is that we are not able to reach the people who are living in slums with these interventions. So then you come to the question of saying, okay, if you want to address the problems of the urban poor, what should you really do? The problems are multifaceted. They are multidimensional. They are a lot. You look at low incomes and all sorts of problems, poor health, and so on. What should you do? There's an effort by the UN and other governments to do slum upgrading, where they are focusing on the infrastructure in the slums. In Kenya, there's one project that is supposed to build, 70,000 houses over a 5-year period. 70,000 houses, how many slum dwellers would it really rescue from the slums? So it's a tiny drop in the ocean, but even implementing that project is an impossible sort of task. It's dragging and so on. So is this really the solution, a long-term solution? Some of us believe that without the political will to address this issue, there's need really to think about bringing services to the people who need them in the slums. And if you've been to many African countries, I mean, Nairobi, in a way, is a special sort of case, because even when you go to countries like Malawi, Ghana, where we've also done work in the slums, there's a very, very big difference between what the government is able to do in these communities versus what you see in other countries like Kenya. So there's a role that can be played in that. Or what combination of these should you be looking at? The other issue is, how much can you achieve really without doing anything about livelihoods? What are the optimal, if we are saying that we already know the interventions that can address these problems, then we have to ask what are really the optimal strategies of delivering these services to them? And those are the areas where research needs to really focus on. And the question of who should really take the drive in resolving these problems. Is this the international community's problem? Is it the civil society organizations? Is it the government? But it has to be a combination of all those. And I think the issue about cost is also very, very critical. So when you look at the unique features of slums, there's the population density issue. I mean, it's a problem in its own for transmission of diseases and so on, but it's also an advantage. You have 500,000 people in Kibera living in this very, very small area. It means that we can easily reach these people. if we are innovative about what to do. It's a cash economy. There are all sorts of things that we need to think about when you think about interventions and so on. But some parting questions on my part is really, I mean, you can ask the question, how do we effectively bring interventions? I think I mentioned that. I think that's one of the key issues, and that's where research needs to start going beyond just talking about the gravity of the problem, maybe which is most of what I did here, to start looking more at what sort of providing solutions to policymakers. But I think the truth is also that I've worked in this field for quite a number of years. A lot of donors are very, very reluctant to invest in dealing with slums. One, they think that the lack of tenure in these areas, that they think that the slums might burn any time. I mean, World Vision told us that with what happened in Zimbabwe a few years ago, where slums were demolished, they lost about over $1 million worth of investment in the slums of Zimbabwe. A few years ago, actually, we wrote a proposal at our center with a big partnership to try to come up with interventions to improve the health systems facing serving the urban poor to one of the donors. But the main reason why they didn't fund us is that they said they didn't see enough commitment from the government to address this problem. So there are a lot of questions that donors have. But I think the question of where do we start? It's a lot of problems. Where do we start? In my view, this is an aerial picture of Kibera slum, which a lot of Kenyans tend to say, surprisingly, sometimes with some pride, that it's the biggest slum in Africa. I mean, you look at Ban Ki-moon, when he became the UN Secretary General, and the first stop in Africa, he left Nairobi airport and went straight to see Kibera. It has become like a tourism spot for poverty. But the question we need to ask ourselves is, what are we prepared to showcase? Are we showcasing the extent of poverty, or are we prepared to showcase what we are able to do as governments, as the international development community in addressing this? I think there's been a very big shortage of really commitment to address these issues, and the focus has been mostly on trying to show the extent of the problem, maybe in our case, to attract money and so on. So I believe that the government has a big role to play, but they need a push. They need the evidence. They don't understand what works or under what circumstances. Research hasn't been focusing on these areas. So if we produce the evidence, the international community puts in the pressure. But even more critically, when people living in these communities make this a big political issue. I mean, you look at Kenya, 2 years ago, we had those hotly contested elections and so on. None of the presidential candidates even talked about addressing slum settlements, problems of slum dwellers. Yet it was the slum dwellers that fought for them when the election was bungled. So I think there's a lot that needs to do, but we need to work together, and there are roles for government, civil society, and everybody in the international community. Thank you.
Thank you, everybody. The tapes are ready. And
thank you.
Martha Campbell.
I will start right away. Yeah. The reason for changing the timing, of course, is because we had such a great time talking ahead of time that we started 20 minutes late. But I want to introduce very, very quickly Dev Patel, and we're so fortunate to have him here. We grabbed him when we heard he was coming into the United States from London, from Mary Stopes International, where he is Vice President and Director of Health Services. Mary Stopes International, MSI, is one of my favorite organizations all around the world. They're working in only 43 countries, and we know them best as being just absolutely fabulous in providing family planning all around the world. So Dev Patel, he has to leave, by the way, in about 20 minutes and head across the bay. So we're very lucky to have him here today. Dhaval?
Good morning, and I hope everyone has enough coffee and that I don't put you to sleep too soon within the 20 minutes that I have. It's really nice to be here. Thank you for having me. Particular thanks to Malcolm and Martha for having me here. It's been about 6 years since I've been back into the Bay Area, but the reason I really love it is not only because of people like yourself, but the weather is wonderful, and after having lived in London for 3 years, where it's grimy and wet and raining all the time, I could stay here forever. So thanks for having me, even just for that minor point. Both Eva's talk and Eliya's talk sort of ended on key points about what do we do in these locations? And I was sort of asked to present an idea about market-based approaches and if they actually do or don't work within the urban slum context for health issues. Let me start by saying, don't label me as a market expert. Don't label me as an urban slum expert. But what I can do is at least talk about some experiences from my organization's perspective, MSI, and what we've been doing in these contexts. And then maybe there's some takeaway messages that might be applicable for the work that all of you are doing for the rest of the day and moving forward. But the real issue is, what are we going to do? Eva called it catalyzing solutions, and Eliya talked about innovations and ideas for moving the evidence base to that. I'm not going to sort of bog you down with lots of data and evidence and slides. I think the case has been made, but instead I would like to talk about the experience more than anything else. Quick background, you can read for yourself what I want to talk about. A few of you asked me during the early coffee time what MSI was, so I've got a few thoughts just to get you up to speed with what MSI does around the world. Some of you may not be familiar with what market strategies and market approaches are for health, so just a general background on that if you're not familiar with that. And then some of the experiences that MSI has brought over the last 30 years from the market perspective to delivering healthcare. And if you've got any questions or comments, if there's time permitting, I'd more than welcome them as well. If we do run out of time, I do want to make it very clear what my answer to the question is as the solution. The answer is clear, it's yes. Market strategies do work for health, and they are very applicable in urban slum locations. This has been applied over the years in a number of different health contexts: malaria, safe water, TB, family planning, so on and so forth, in different ways. And I want to speak to you particularly about one of those strategies as part of the entire market approaches that exist. There are challenges, there are difficulties, many of which you just heard about earlier from Eliya, but it does work as a concept in theory and in practice. For those of you who are not familiar with MSI, just a few background points. We're a global organization based out of the UK. We've been around for 35 plus years. We have a general mission, which is to children by choice, not chance, with the aim of reducing and or eliminating unwanted pregnancies and in particular unsafe abortion around the world, particularly in poor and vulnerable locations. Malcolm was one of the earlier proponents with our founder Tim Black and Phil Harvey and so forth, giants in the field that you probably have come across, or at least read about over the years. As part of that, more recently, we do focus more and more on delivery of information, services, and product as we are trying to engage in strengthening the health systems that exist on the ground. In terms of health domains and health areas, we are primarily a family planning, sexual reproductive health organization. We do a fair amount of safe abortion, post-abortion care in all of our countries. But over the years, depending upon need and issues, we've gotten into integrated HIV/AIDS, family VCT, male circumcision, PMTCT, maternal and child health, whether it's PPH more recently. We deliver babies. We offer ante and postnatal care. And generally speaking, because we have infrastructure on the ground in all of our countries, we are seen in many ways as a location to offer curative or general health counseling and help as well. But again, the primary focus is the very first bullet point: sexual reproductive health, family planning, and in particular, long-lasting permanent methods. You can see the map for yourself. We're in 43 countries over the last 35 years, mainly in Africa and Asia, a little bit over in Latin America, and most recently, in the last 3 months, we have a presence in Washington, D.C. with a new representative as well. How do we get all of this health work out into the field? And then I'll jump into explaining what I mean by market approaches. In all of our countries, we have at the core our static MSI centers. And these are typically in urban locations or peri-urban locations, and will range from premium clinics to slum clinics and everything in between. Some countries only have one. clinic. Others, like Pakistan, one of our biggest programs, will have up to 100 clinics in various locations. But the core of what we do is centered on the MSI static branded clinic with lots of quality with providers and the portfolio. Over the years, in particular, it's become increasingly visible that we cannot continue to have access and increase access in an equitable way unless we started branching out. So you see the sort of branches from the static center. We have a fair amount of work going on through outreach and community-based distribution and mobilizers and so forth, where we go into deep rural pockets of countries where the need is great, and one could argue is as great as the urban locations in some of the cities that we work in. That has limitations. As a result, in the last 3 or 4 years in particular, we've engaged in social franchising as part of the entire market through which health is delivered, which I'll speak a bit more clearly about in a bit. But Eliya made a reference to it, which is essentially organizing the disfragmented private providers or informal providers that exist in these communities, i.e. the non-state providers, in a way that allows you to, as part of the entire market, deliver family planning services and products and information. And on top of all that, depending on what country and the context, we do sell and distribute and provide products through the commercial structures that exist, i.e. social marketing as well. But this sort of describes the entire package of MSI in a given context, in a given country, to achieve our goal and mission. And we don't do all of this in every single country, but at least the core of it does exist, which is the MSI Static Center. So that's the sort of quick background on MSI. If I had to ask you for a definition of what a market was, and a lot of this does come from, the business world, the marketing world, the MBA world, if you're all familiar with some of that sort of stuff, you'd get 1,000 definitions. But I thought because I was asked if these approaches do work in the context that we're talking about, I should offer at least a definition for a market. I won't do that for urban slum stuff. You are all better experts at that than I am. But a simple definition which you can read for yourself. It's simply a location where you've got someone selling something, someone that wants to buy something. There's an interaction, and there's supply and demand for products and services in a health context. Seems pretty simple, but when you start to dissect it, there's a whole science and art to understanding what that market really is about. Over the years, across different health domains and areas, there have been different ways to capitalize on that definition of the market. In the early 2000s, about 10 years ago, you had groups like DFID, which is the British Development Agency, and USAID starting to ask questions along with KfW, the German funders, what the entire market was and how we could capitalize on that in a health context. And what you really realize is you had the private sector that was out there, that was for profit. You had the government sector, and then you had groups of individuals and organizations that were in between. And that if we were going to actually deliver health, that we had to grow the entire market, the public, the private, in between, collectively, in order to deliver the services and products and information that we were talking about. And as a result, you could start to take that market and segment, ultimately, the buyer or the consumer or the client on various levels of degrees. Socioeconomic status, high, medium, and low, and begin to target those individuals in the market and then figure out what their ability or their willingness to pay was, i.e. how much cash they had in their pocket. And the idea was that you would try to match up that market, let's say high, medium, low for the consumer or the buyer, to the source of where that health product or health service was coming from. In theory, what would you like? You would want the poor and those that are low socioeconomic status to acquire their health services or products or information from the government sector, i.e. that's offering free services or products, and those that were on the other end of the continuum that were higher socioeconomic status or had a higher ability or willingness to pay should probably acquire their health products or services from the private sector. And then there's a group in between that should acquire from the middle. And if you're familiar with social marketing, generally speaking, that principle was sort of the middle group. But you should then, as a total market, be able to have sources of supply of products and services that matched up based on the consumer or the buyer in that market. In theory, that's what should happen. In practice, it really doesn't always work that way, because there's enough evidence out there, and I said I won't bog you down with slides, where the rich still don't want to pay and will still go over to the government sector or the very highly subsidized source of supply, which is at a lower cost. And there are a number of cases around the world where the poor, the vulnerable, or the low socioeconomic groups will actually say that they have the ability and the willingness to pay for a higher product or service because it's higher value, it's higher quality, it's a premium product, and as a result, that sort of total market doesn't work very well. So what do? You've got to come up with strategies to help equalize that market. There's a number of them, and I'm just going to sort of focus on a few and then spend most of the time on one of them. There's a notion that if you can get private sector commercial supply going and the volume or the demand is great enough from the buyer, that these commercial private institutions should start to reduce their prices to a point where it's very, very low, which should then help to stabilize the entire market. On the flip side, and I like what Eliya did, there are in Kenya and other countries a number of private providers that already are existing in urban slums that are doing a number of different health areas. As part of the entire market, could we not organize that group in a creative way, then offer services and products at a certain price that would allow you to reach the poor and the vulnerable in those different environments, and then figure out, and I think you mentioned this, innovative health financing schemes that would match that to reduce the out-of-pocket payments those individuals were offering. So total market approach for health, and then some strategies, either getting the private sector or the government sector to work together to deliver that stuff. If you're familiar with health financing schemes, generally speaking, this slide is probably not new to you, but if you're not familiar, what you will see on your left-hand side is sort of the old approach in terms of how health services, health products were sort of financed. You'd have a donor or someone that was subsidizing this, and they would pay for inputs. They paid for your salaries and your overhead and your building and your commodities and sort of tried to build a supply for the market. Then that was sort of given over to the service provider, and then you finally had outputs and services being offered. Highly ineffective, highly inequitable, leads to a lot of fraud and corruption. Over the recent years, there's been a change in that model, which is let's not pay you anymore as part of the entire market for inputs. Why? Because MSI, you already have infrastructure. You have clinics, you have service delivery, you have outreach programs in urban and rural locations. We will pay you for your output. So for every service that you do, we will contract you and pay you $10 for every IUD that you insert for family planning, which then puts the accountability on part of the provider rather than the donor or the person that's subsidizing the entire market as part of this. So this OBA approach, output-based aid, paying aid for outputs, has become very in vogue as a health financing means to grow the entire market in an equitable, efficient way. So that's a bit of the sort of theory on the market approach, and there are some measures that individuals sort of speak about regularly in terms of market strategies for health. Again, terms you all are familiar with, you've used them, but there's a precise definition that we can offer for each one of these terms. Are market approaches viable? Yes, because they're effective, they're efficient, they're equitable, and they increase access. In terms of effectiveness, I'm offering a definition which is the market approaches work as long as you've got people that are using the product or service that you are trying to engage them to use. It's an efficient way of increasing stuff in urban slums by looking at the market share that the source of supply has. In other words, how much of the product or the service is the government providing, the private sector providing, or in between. And you want all three to go up, otherwise what you will have is stealing, or you will have substitution. People that should be going to the private sector don't, and instead they're getting their supply from the other side. Equity. You've got different levels of individuals of need in a group of people in an urban slum, for example. You've got some that are older, some that are younger, some that are richer, some that are poor, just like all the slides that we just saw. You want to ensure equity among that group with regard to your service or product, and you want to see equal use of those services or products. If not, the system is not equitable for them. And finally, access. You want your services or product through a market approach to be close to where your consumer is. Otherwise, they potentially may not use it, whether it's objective or perceptual. So you can use these measures as a way to indicate to yourself whether or not you have set up a proper market approach or not. A couple of challenges, and then I'll switch to the example from MSI on social franchising as a way to engage the entire market. Most of the markets that we see out there currently are inequitable, as I've said before, or they're unsustainable. Why are they unsustainable? Because right now they require an outside donor to pump money into the system, either to build the government sector in order to provide this stuff and keep it going, or it requires money for the product or service, even if it's the middle group between the public and the government. So it's inequitable and it's not sustainable. What do we do? Well, we know where it can and how do we change this? There's this other notion of utilization of the services and funding to the poor and the most in need. Again, some of the slides that we just saw earlier, there's an inequity built in right there. The people that should be accessing aren't able to access, even though money is going to that group. Why is that? What do we do about this? And finally, how do we actually encourage, this is the challenge to this, how do we encourage the for-profit commercial private sector to reduce their prices, whether it's pharmaceuticals, whether it's products, whether it's anything else, in order to have great demand? As a result, you build an equitable system. How do you motivate that sector? So keeping those challenges in mind, the solution, or one of the solutions that MSI is engaged in, is really to build a social franchising mechanism. Private providers, organizing them in a certain way that already exists in the urban slum locations in particular, which will then increase equity with something called a voucher. A voucher is simply, let's say it's a ticket that you get if you want a family planning service, or if you want a safe baby delivered, and someone else is paid for that voucher. So you then, who ordinarily could not afford it, will go to a private provider who then offers you the service. The voucher then is turned over to the person that's subsidizing it. Let's say in this case it's the German government or another government, and then they reimburse that private provider for that service. We started doing this as an organization in 2007. I'll just skim over this, but this simply sort of reaffirms what Eliya was saying earlier, that most of the expenditure is happening at the private level rather than the donor level or the government level. And in 2007, we started looking out at who the private providers were. There's a whole array of private providers that already exist in communities, from pharmacists to informal to village health workers. How do we organize them in a certain way in order to then accredit them, to train them, to provide them with supplies and products so that they can then in turn get the buyer or the client to come to us? And so over the last 3 years, we have built something called Blue Star as a way to build the entire market in locations, a lot of it geared to peri-urban or urban slum locations. We have this in 9 countries now. Oops, I don't know how to go back. Sorry. You saw the map. 9 countries. There's a thought that we will probably get into about 13 countries in the next 2 years as a mechanism. And what we do is essentially go into, let's say, the urban locations and figure out where the private providers are. So there's a mapping and a baseline data that happens. How do I? Oh, there we go. We select certain providers that are already there based on certain criteria, and we then set up a agreement with them. They will sign a contract, MOU. They pay a fee of some kind to MSI, and in return, we provide them with training. We provide them with accreditation. We then, over the training period, we brand them. They're called Blue Star. We then offer them marketing tools so they can suddenly start to get an increase of new clients that ordinarily would not come to them. Some of them that will have a voucher that can get the service or the product subsidized. And if it all goes well, their client numbers in these locations, in urban or peri-urban locations, should go up. And then we offer monitoring and evaluation auditing functions to ensure that the quality and the training that we've offered them is actually paying off. Oh, no, I'm going the wrong way. Oh, there we go. And here's sort of a before and after. Here's sort of a peri-urban location. You see on your left-hand side what it used to look like. We came in and refurbished, trained them up, rebranded them into Blue Star within that environment. And keeping in mind that these private providers are already doing a number of services before we approach them, we will only partially franchise or partially guarantee the quality of certain types of services that are useful to MSI, particularly those on long-lasting permanent methods. But you see a gamut of things that these providers are already doing in the 8-9 countries that we have Blue Star going in. Here's an example as part of the entire market to help with equity, vouchers that have existed in Kenya that were funded by, impartially, as I probably knows, the government and by KFW for safe motherhood, for family planning, so on and so forth. So women in the community would get these vouchers, they would take them to a service delivery point, and then would get the service, and they would have to pay very little. And the last few slides are just about, does this stuff really work or not? If you take that market approach for social franchising, you will see that, at least for organizationally speaking, there is an increase in a couple of years of protection. I'm just going to take it for granted you know what that means. If not, we can sort of answer that briefly afterwards. But you see from 2000 to 2008, MSI's bottom line, a couple of years of protection going up nicely. I can't figure out, technologically speaking, how to add the 2009 number into the slide, so I haven't. But the 2009 number is 17.1. So again, the trajectory works quite well. And a portion of that is coming from the Blue Star franchising model with regard to the market. The other slide that I have is here's just 2008 numbers. And we broke down our service numbers for long-lasting permanent methods by the delivery channels. The static clinic that you saw in the core model, the outreach model, and then other. Other is really primarily franchising. And you see in 2008 that almost 10%, the bottom number towards your right, represents the amount of services that we offer for long-lasting permanent methods. So again, we started this out in 2007 as an organization, and already the bulk of the franchising numbers for long-lasting methods represents the 10. So a nice sort of market example there. And my last points here is, again, going back to the first slide, is this viable? It is viable. MSI, as one organization, is doing it. But in order for it to be viable and to have scale, you've got to have two major things in place. You've got to have lots of demand. Clients want to know where to go and how to get these products and services, but you've got to have the supply. If you don't have the demand, you won't have, if you have demand, you don't have supply, then you're going to be in an inequitable, unsustainable situation again. The supply is the franchising model here that we've tried to build in certain countries. Second, consumers are willing to pay whatever they can afford. This goes back to segmenting the total market, ability to pay and willingness to pay. And some of them really do think, there's evidence for this, in other health areas, including safe water, that the more I pay, the more value that I get out of it. It's like Coke. If Coke is branded versus a non-Coke or a non-soft drink that looks like Coke, it's not branded. I always feel the Coke is better, even if, because it costs a little bit more, it looks better. That same sort of principle seems to apply in the health services, health products arena as well. My last point is, if you want this to work, you can't just have in the urban locations, on the sub-locations, one product or one service. Competition is necessary. Multiple brands are necessary to grow the entire market. And in some cases, there are countries that are out there that have essentially branded the government sector service or product, which is unusual because most government supply is not branded. It's free. You go into Vietnam as an example, where they've asked Maury Stopes to help them with their the government franchising brand, and it's called Sisterhood. And it is a franchised government sector brand, again, that increases the entire market overall. So does it work? The answer is yes. Is it difficult? The answer is yes. Is it something that we should consider moving forward? I think so. And if you want any help from MSI in this area, we're more than happy to do so. Thank you. Are there any, happy to answer questions or comments, or are there any thoughts?
How do you create demand for products and services in slum communities that they're not already aware of? For example, if you're promoting a product that they don't know, like what it's going to do for them or what benefits it will
At least the franchising model that I've quickly just gone through with you, most of the franchisees are pharmacists or midwives or something like that, and they typically have on their payroll a community-based gatekeeper or community-based mobilizer that is part of the community, and she will then take services, take products, take information, and actually, in our case, walk around in these locations and just start talking about the product. Start telling people that you should go to this Blue Star provider. A lot of it's just done through word of mouth in these communities because that private provider already existed in that area, have someone on payroll, and then they go out and just start talking about it. That seems to be a very effective, very efficient, cheap way to get new ideas into the community, at least from this perspective.
There's a lot of evidence, a lot of evidence that shows that fee-for-service increases utilization and increases access. And I'm just, but obviously in slum areas all over the world, there are a lot of private providers of all kinds of services where people pay.
Mm-hmm.
So I can see where this fits in terms of coordinating and ensuring quality and standardization and all of that. But I'm wondering how MSI works with ministries of health that are trying to put in place a universal system or access to universal care.
Good question. This sort of becomes a bit of a debate on whether we should be charging or not charging, and whether people are willing to pay or not to pay. Putting that aside for a second, in countries where countries are trying to provide universal health care and reduce out-of-pocket payments to essentially zero, we are trying to work hand in hand with governments and saying, look, you still, for a period of time, could be a number of years, need a couple of things. One, you need for us to come in to help you strengthen what systems you have on the ground. So we will work with you to build your capacity, to train you up, or two, even while that's going on, you may still need for us to be contracted in or out to provide some of the services that you're trying to offer. So if you have a shortage of healthcare providers on the government side and they can't be trained up, why don't you contract out MSI or contract out Blue Star for a period of time, pay for every service that we deliver for you. The client still can get that for free, but instead of you spending it on your own, spend it with us, and then over time, you just transfer that back over to you. So we're talking about contracting as a means for a period of time to help make that happen.
So then the idea would be to transition that back to the MSI clinics, the Ministry of Health clinics?
No, they would not be Ministry of Health clinics. They would still stay as MSI clinics because you have people out there that do not want to go to the government sector, do want to come to the MSI clinics or to other private providers. So we would still need our clinics for purposes of servicing them. But what we're saying is look, government, you need help. We're willing to help you. Contract us to help you with that. Just pay us the money that you would have spent on your own side for a period of time so that we build that up, and then people can make a choice over time. They go to you, or they come to us, or to another private provider. And that still is in line with their notion of providing free and reducing out-of-pocket payments to the group that wants to go there. Yes, Paige.
Yeah, you mentioned preventing inefficiencies and corruption by not having donors give money to the inputs. How do you prevent corruption on the output side if certain services are more expensive for the providers to give, like C-section versus normal delivery or IUD versus condom? How does that work?
We need to figure out what the average cost of these services are to begin with. And most of the donors that want to fund that have mechanisms for doing that with the service providers. And then there is a contract that essentially is signed between the donor and the service provider, and or usually in some of the bigger projects that have been funded this way, there's a consortium of stakeholders that are sort of governing these major projects because they are still big pilot projects in many ways. And so there's oversight that's being done once those contracts are happening. And then there's usually a management agency as a third party that validates and does M&E to ensure that service providers are not charging more than they're supposed to be, and the numbers that they're reporting are actually accurate.
Thanks.
Sorry, okay, yeah, there's the thing.